So very good evening, everyone. It is first Friday CME series of Indian Association of Biological Psychiatry that was started way back almost 6 months back. And last month we didn't have because we had our annual conference of biological psychiatry, which was held on Zoom. So here we are again on Friday, first Friday of the month of November. And we have a very relevant topic, and that is being almost everybody said that we need to listen to it and in fact learn it again and again. And for this we have a very elegant speaker for the evening, and we have two very reputed chairpersons as well. The topic for today is advanced in autism spectrum disorder. And with us, we are privileged to have our chairman of CME committee of IABP, Dr. G. Prasad Rao. I would like to request and invite Dr. G. Prasad Rao to deliver the welcome address before we introduce our speakers.
Thank you, Majid. First of all, happy Deepavali to every one of us. I think we just finished the Deepavali and our festival season has just ended in a way, and we are starting our biological meets. I think every month, every alternative month, we have the meeting, and thanks to Majid and our secretary, we always have a rich academic feast. So this is time to again welcome the learned academia into our biological psychiatry and the lot of members who are participating, and they have come to listen both through this meeting, web meeting, and also I think it's also being kept in the website as well. And I'm also happy about the chosen topic. Like my favorite topic, dementia, autistic spectrum disorder is changing quite a lot year over year, and we are getting into know definitely much more every year. And I'm sure both the speakers will do the judgment. And this is my privilege to welcome each one of you, and hope we'll start meeting at multiple places as the conferences have started occurring. Thank you, Majid, and happy academic conferences from now onwards for the whole year.
Thank you very much, sir. Thank you for your words and for your pleasantries. And you have been always a mentor, and you will keep us blessing all the time with your presence and with your speech. Thank you very much. And this program would not be possible without Dr. UC Garg, who is our president, Dr. Sunil Mittal, the vice president of IABP, Dr. Pramod Kumar, Dr. Anukant Mittal, who is there, we had Dr. Akshita Seda, who would normally anchor this program, but today she is traveling, and Dr. UC Garg is also traveling. We appreciate and acknowledge their support, and always they have been there anchoring this program. And thank you all the IABP members for attending and for appreciating this series of programs that we have been doing. Before we go on to the speaker, we have actually two very important people on the panel. That is Dr. Kersi Chawda, who is the chairperson for the event. He is a dear friend. He has been president of Bombay Psychiatric Society. He works as a consultant in PD Hinduja National Healthcare. He has been a member of many task forces, including LGDP, and we had a very important decision on LGBTQ through the Supreme Court of India, and he works with the college psychiatry of Indian Association of Private Psychiatry. Currently, he is advisor of IPS task force dealing with LGBTQ. He has been in service as a psychiatrist, practicing psychiatrist for 35 years, and his field of interest is relevant to today's topic. He has been very keen in learning, reading, treating, and helping who the kids are there and who are suffering from different psychiatric disorders, particularly the learning disabilities that he is dealing with in Mumbai. He has written 3 book chapters, and 2 years ago, he was awarded the prestigious Dr. S.N. Lula Oration. You are welcome, sir, Dr. Chawda, sir. Then we have second chairperson, that is Dr. Nitin Gupta. He is the past president of Indian Psychiatric Society, and he has actually post-graduated from PGI-MER Chandigarh. He worked as a consultant in at different places, starting from he was an assistant professor in PGI-MER Chandigarh before he went to UK and worked there as a consultant. And now he is back in Chandigarh working in private sector. He has been awarded as Kataria Memorial Gold Medal of PGMAR in 1996-97. He has immense research experience. He has a lot of publications. He is editor of Indian Association of Social Psychiatry, and he is associated with many other associations as well. More importantly, he is a very avid clinician and academician. It is over to you, Chairperson, sir, to introduce the topic and introduce today's speaker, Dr. Mansi, as well. Over to Dr. Chawda and Dr. Nitin Gupta.
Thank you very much, Dr. Majid. I think I'll start off with introducing the topic, and then Dr. Chawda can introduce our speaker for today. I think autism spectrum disorders, as now they're defined in DSM-5 and ICD-11, is a very complex condition, and we are learning more and more about them with each passing year. And efforts are being made to understand more and more about how to manage them. Although the mainstay of autism spectrum disorders remains behavioral management, but pharmacological treatment is also being something which we clinicians are always trying to explore, especially keeping in mind the behavioral difficulties which we encounter with these spectrum disorders. And it's not only the behavioral difficulties, but it's the associated comorbidities in the form of intellectual disability, medical comorbidities, and the psychiatric comorbidities which tend to occur with ASDs. I think a lot of advances have come forward in the last few years, which I think the speaker would obviously be covering, as that is the topic for today. And it is. I was reading somewhere that probably nearly most of the patients with ASD tend to be nearly 50% of them tend to be on one psychotropic at any given point in time. And if they are having comorbidities, nearly the value goes up to nearly 60 to 65% of them being on medication. And sometimes they are being prescribed 3 medications at any given time. So it's not that pharmacological management is uncommon. In fact, it tends to be quite common. But the important thing is that are we judiciously using the medical management with ASDs? Number one. And secondly, as to whether it is targeted intervention. And I think that is something which is important to keep in mind. The other thing is that newer medications, how effective they are proving to be at the moment, although experimental trials have been carried out, and recent advances have also suggested some form of gene therapy also being used. So these are some of the questions which come to mind. I'll not want to take up too much of time for the speaker also. So with these few words, I'll pass on to Dr. Kersi Chawda to introduce our speaker and to carry on with the program for today. Thank you very much.
Thank you, sir. Today we're going to have Dr. Mansi Somaya, who will be speaking on this topic. She's young, she's enthusiastic, she's reading, she's willing to go. She's a consultant psychiatrist of the Learning Disability Clinic and the School Mental Health Clinic, Department of Psychiatry, the TNMC, and the BYL Nair Hospital, Mumbai. Dr. Mansi, you have about 45 minutes. Please go right ahead. Thank you.
Is my screen seen and am I audible?
Yes.
Yes, okay. So thank you so much.
Sorry, Dr. Mansi, if you could just make it the full screen, please. That would be helpful.
Yes. Thank you so much, Chawla sir, for your kind words of introduction. And thank you to the entire team of IABP for inviting me for this presentation. Thank you, Majid sir, Dr. Rao sir, and Dr. Alka Subramaniam ma'am, who truly believed in me and sharing my understanding on this very crucial topic. I think uh, Dr. Gupta sir has already sensitized us with the need of studying this topic, which has actually intrigued all of us, whether we are a researcher or whether we are a clinician, because there is so much heterogeneity in terms of the phenotypic manifestations for a clinician or even for a researcher who's struggling to find that one molecule or that one gene which is which can be targeted for intervention. We are all seeking and looking out for the best modality in treating the various symptoms which come as a part of the presentation to us when patients come to us. So the scope of my presentation would involve the different symptoms of the disorder, what we exactly know, what are the molecules which have been used, and what does the future hold for us, what have the recent advances been. It's been a struggle to define an advance, because there isn't a defined timeline that one can draw. But if 1938, as was when autism was coined, then perhaps till 1922, I would rather consider the last 2 decades, right from 2000 onwards, as advances in that sense. And hence, a large part of my presentation is on pharmacological advances and not on non-pharmacological advances, because they came in right in the right from the 1970s, etc. onwards, and a take-home message. So we know that it's a syndrome which is characterized by an impaired social communication and interaction deficit. We know that there are deficits in emotional relationships and the various restrictive, repetitive behaviors which can come either in speech, in actions, or in higher order repetitive behaviors and sensory issues. But comorbidity, like Dr. Gupta highlighted, is seen almost in 2/3, of individuals with autism spectrum disorder, and can be one reason which can compound the core deficit of social communication issues in such patients. So uh, behavioral interventions have always stood the test of times, and their focus is on the core deficits. But when it comes to comorbidity, there have been a lot of literature evidence in understanding these various symptoms and also in terms of interventions. So let's try and understand them symptom wise. What are the interventions available? So I'm going to start with irritability seen in individuals with autism spectrum disorder. So they can manifest in different ways. Irritability is characterized by vocal motoric outbursts, and they can, the individual can express it as anger, frustration, or distress, and come out as temper tantrums, or it could be a problem behavior in the form of a directed act of aggression. It has this emotional dysregulation has a neurobiological basis and can co-occur with mood and anxiety disorders. Now, the dopamine system here is very, very significant, and an abnormal dopamine system is responsible for the abnormal signaling in these various circuits which are involved. So there are two neuronal dysfunctions that have been identified by dopamine. One is the mesocorticolimbic circuit. Now we know that it is responsible for motivation. It is responsible for, the social experience. The reward pathway is responsible for the same. So if there is an abnormality in the dopaminergic system, it will lead to failure of registering in the social experiences as rewarding experiences, which will, as a result, reduce the motivation of that individual to even seek that social encounter. And that explains the deficit in social interaction. But there is another component which explains the behavioral issues, the repetitive behaviors, those aggressive behaviors, is by means of the nigrostriatal circuit dysfunction. So there is a connection between the substantia nigra and the dorsal striatum, which we call the nigrostriatal pathway. When there occurs a suppression of the dopamine transporter, so either it could be a polymorphism like the SLC6A3 polymorphisms, which are responsible for the repetitive behaviors. When there is a suppression of the dopamine transporter, the dopamine from the synapse gets accumulated, and there is a dopaminergic excess which contributes to the behavioral issues. The dopamine does not get cleared and does not go back to the cytosol, which explains the motoric outbursts that we see. So a D2 antagonist will, in that way, will block the dopamine transmission, and as a result, it has been implicated in behavioral improvement. So right from the start of 2000, there have been studies where they have used it in terms of atypical antipsychotics. Risperidone has been used in various randomized control trials, and this study by the McDougall and the RUPP, which is the research unit of pediatric psychopharmacology study, which have been landmark studies where risperidone has shown its superiority over a placebo. And there has been improvement seen in irritability, temper tantrums, and aggression in this population. However, it also comes with some side effects which are well known to us in terms of weight gain, increased appetite, fatigue, somnolence. And hence, risperidone, despite these side effects, has been approved in the year 2006 for individuals about 5 years of age. Another molecule which has been tried is aripiprazole, and again there have been 2 landmark studies which have proved the efficacy of aripiprazole in treating irritability in this population, and as a result it was approved for individuals with autism from after 6 years of age, and this was in the year 2009. So in that sense, although both these molecules have been used, there have also been head-to-head trials between them, comparing them with a placebo, and they have also seen, although it was proposed that perhaps aripiprazole may not cause so much weight gain and the issues that come with risperidone, there have been some reports where where it has increased the BMI score. So in that sense, even aripiprazole comes with certain side effects. So what are the other molecules which are available to us in also risperidone, aripiprazole have, there are other studies and meta-analysis which has supported the efficacy of the same. Clozapine has also been used, and in a study which was carried out across 5 years in patients who had refractory symptoms of irritability and aggression, who were on clozapine for 11 years, and a pre-treatment and post-treatment after 6 months assessment was carried out, where they found that there was decrease in the days of aggression in such a population. They well tolerated clozapine and did not have so many side effects. But yes, we have to be careful in this population because it can cause weight gain, constipation, tachycardia, and other very serious side effects in the form of seizures, agranulocytosis, myocarditis. But yes, in children where rapid control is required, where symptoms are refractory, this is one molecule which can be used. Another molecule used is olanzapine. Now, there have been very few studies. In one of the studies, they have shown improvement in a 3-month trial, and another trial, there was no improvement at all. And weight gain was one concern, which we know is a concern in case of the usage of olanzapine. So there have been mixed results, but unfortunately, there are no long-term studies which have conducted using olanzapine in this population. The results are largely from open-label studies. The other reports are from quetiapine, again from open-label studies. With ziprasidone, we have to be careful of the cardiac changes that can occur. And paliperidone has also been tried in these patients. Lurasidone was also tried in a double-blinded RCT, but there was no improvement seen in this population. Amongst the first generation antipsychotics, haloperidol has been used, and they have seen improvement in stereotypy along with the improvement in social withdrawal. But again, the problems that come with the first generation antipsychotic, and since the problems continue for long, there would be a long-term usage of haloperidol, which again predisposes the children to the neurological side effects. So that is one thing that we need to be careful about. Now, long-acting injectables, ironically, have not been used and rather tested in this population, since this population is so vulnerable to issues with compliance, or even may struggle with swallowing, right? So this can be one of the very options that can be used. But they have used, in one of the case reports where they have used paliperidone in a patient with an individual with autism, and they have seen improvement in the irritability on ABC, which is the aberrant behavior checklist, and the CGI scores. Another study, which was more like an observational retrospective study, where they have seen patients of different neurodevelopmental disorders, one of which was ASD, and they saw that the long-acting injectables were quite well tolerated. So this is one option, although the data is very scarce, but it can be a very useful option in this population. Irritability in autism is also implicated by the pro-inflammatory state and the glutamatergic excess which occurs in the brain. And another molecule which has been tried especially to reduce aggression and irritability is N-acetylcysteine. N-acetylcysteine is like a renoprotective antioxidant. It's like an anti-inflammatory drug, which we know is used in acetaminophen overdose, and it reduces the excitation caused by glutamate. And as a result, when it is used early on in this population, the glutamate excess, which is responsible for abnormal, differentiation in the synaptogenesis and the plasticity, it modulates that when it is used. So there have been studies, and in the last decade, where they have used it, comparing it with placebos, and they have seen improvement in irritability in these patients. And one of the studies, they have used it with an augmenting agent in the form of risperidone, and they have seen some difference in irritability. However, larger clinical trials need to be conducted to assess the response and clinical use. Another molecule which is currently being tried, and the clinical trial has just gotten over in this year, is brexpiprazole, which is being used in schizophrenia and depressive disorder, but yet the safety and efficacy in this population has not been determined. Now, what happens in a brain with the autism spectrum disorder, in a child with autism spectrum disorder, is that the GABA, there is a GABAergic deficit. Okay, a GABA, which is the inhibitory neurochemical, is decreased, and the excitatory glutamatergic transmission significantly increases. So there are various, etiological factors to this. One is the alteration of GABA synthesis, which is seen to be reduced in this population, or there is reduced GABAergic gene expression. And hence they have tried those modulators which increase GABA and reduce glutamate. So we'll come across some of these molecules now in this presentation, which increase the GABA and reduce the glutamate. So for example, there is arbaclofen, right? So it's a GABA B facilitator. It's going to increase the GABA. GABA is going to inhibit the glutamate, and as a result, the excitability of the neuron will come down, irritability will come down. So that is the mechanism, and they have actually tested this, but this is an open label trial where reduction in irritability has been seen. In another RCT, there has been no change. So there are very variable results when it comes to even these modulators. There have been other modulators, GABA modulators in research, like bumetanide, which again facilitates GABA, and carnosine, which again enhances GABA. There have been improvements, but the research data is very, very limited in that sense to call it like an established evidence. Another molecule which is often used in the neurology side in amyotrophic lateral sclerosis is riluzole, which again works in the same mechanism. It has been used in one of the studies along with risperidone, and they have seen differences in irritability and aggression. But again, there is no well-established evidence for riluzole. So valproate is another molecule, and I think often it has been used, especially when it comes to refractory cases, which facilitates GABA, and it has been used into double-blind RCTs. In one of them, there was no difference when compared with placebo, and the other there was a difference in irritability. So again, very mixed results. Other mood stabilizers like topiramate has been tried along with risperidone, and it has seen that there has been improvement. Levetiracetam has been tried but not supported by an RCT. Right? But again, these again are under research, and there has not been many studies which look into it. Electroconvulsive therapy is also being tried in children with in individuals with autism spectrum disorder, especially when they have when they have aggression, self-injurious behaviors, and they have seen a difference in self-injurious behaviors and even in catatonic symptoms in this population, especially when in this review mentions specifically where cases where even maintenance ECT has been used in this population. Another very significant co-occurring condition with ASD, which is almost prevalent in 50 to 60% of children, of individuals with ASD, is attention deficit hyperactivity disorder, which has a neurobiological overlap with ASD, which is seen in neuroimaging studies by similar areas being involved, very similar neurocognitive functions being involved. And there has been a landmark review which has a meta-analysis in that sense, which have looked at the role of methylphenidate, and when they've compared it with placebo, where they have seen that it is superior than placebo in the treatment of ADHD symptomatology in this population, and specifically shows improvement in hyperactivity and also in irritability and stereotypy. Right, so it can be used, but it comes with its adverse effects. It is seen that children with ASD were more prone to the adverse effects with methylphenidate. So they had a more decreased appetite, they had sleep issues, they had more depressive features, irritability levels were higher. Atomoxetine, the other SNRI, which is being tried, and it has shown improvement in hyperactivity. Again, we have to be careful of the side effects, but just like other individuals, children with ADHD, we can also try atomoxetine for children with ASD and ADHD. Clonidine is another molecule which has been tried with in this population, especially in those individuals who have side effects with the first line or with poor response. However, there's limited evidence, and it has largely been very small sample size studies that have been used. And it can be particularly used also, apart from hyperactivity, and irritability, stereotypy, in cases of mood instability. Another molecule which has been also used in hyperactivity and self-injurious behavior is naltrexone. So the basis of which lies by explaining the brain opioid theory of social attachment. So the social behavior is the social and affiliative behaviors in human beings are dependent on the levels of endogenous opioid peptides. And what they have seen in brains with ASD is that their endorphin levels, enkephalins, are very high. So they make them very refractory to pain, refractory to reward. And that is why their motivation for a social encounter is very less. So when the brain is flooded with endorphins, there is a delay in maturational manufacturing of enkephalins, and they prevent it from becoming responsive to the sensory and social environment, which explains the social deficits in autism. And there have been animal model preclinical studies, though, where they have seen opioid receptor dysfunction, a low opioid tone in patients with social behavior deficits. So animal studies explain this, that with opioid administration, this is seen: decreased socialization, diminished crying, insensitivity to pain, the motoric symptoms. And hence there is a growing interest in the use of opioid antagonists in this population. And they've actually seen, there have been studies where beneficial effects of naltrexone in reducing hyperactivity and irritability, but they fail to detect any improvement in the core autistic features. And there have been some studies which have examined the effects of opioid antagonists in this population, and they have seen a decrease in self-injurious behavior, hyperactivity, restlessness in this population. Acamprosate is another molecule which has been tried, and they have seen improvement in hyperactivity. But again, there is not enough established evidence. There are not enough trials to call it like an established evidence. Another common comorbidity is OCD, and one of the difficult challenges is to differentiate it from the repetitive behaviors, which is another defining feature in autism spectrum disorder. So it's difficult to differentiate between the two. Again, OCD is almost 6 to 37% comorbid when it comes to with ASD, and because it's so especially if their children are younger, or if they have a lower intellectual functioning or a speech delay, it may be very difficult for them, one, to even understand their thought process in terms of understanding the obsessions and even articulating them, and hence a functional behavioral analysis will be very important in differentiating the two. Categorically, RRBS, which is the repetitive restricted behaviors and symptoms, the purpose is, there's more egocentristicity, and in obsessions, it will be more distressing to the patient. So RRBS would largely be the child or the individual will look for escape, look for attention or stimulation, right? Now, what is new, or what are the advances in the treatment of OCD in this population? CBT has been tried, but there have been very mixed results. And that's also because in lower functioning population, lower functioning ASD, or in those with cognitive disability, it will be very difficult to use cognitive behavior therapy. But wherever they have in high functioning individuals or even adults, the focus has been to make them or enable the individual understand affective education, in the sense understanding their emotions, identifying certain physiological cues, which are associated with the anxiety, like a shallow rapid breathing, or a discomfort which is experienced, like a dry mouth, or whatever that comes with anxiety, and identifying the antecedents, right? Determining what are those triggers, what are the cues, and gathering information based on that, and making and enabling the the hierarchy formation along with the patient. So SSRIs and RRBs have also been tried, but again, the efficacy is mixed. Low dose fluoxetine, when used in a study, there was a decrease in repetitive behaviors. When used in in a higher dose, they found no significant difference. Citalopram was used, and there was no difference, which was found in another study. Fluoxamine has shown efficacy in some studies, but has seen they have seen behavioral activation. Clomipramine, there was a decrease in OC symptoms. Antipsychotics have also been tried in this population, and along with irritability, when risperidone was added, they saw a decrease in obsessive and compulsive symptoms when it was used in higher doses. Even aripiprazole, when used in this population, reduced irritability, and also they saw a decrease in the CY-box in these children, which could explain their use in conditions where OCD is not improving, or as an augmenting agent. But still, the role is unclear. Another advance in terms of the behavioral management in this population is that more in vivo exposure, more real life exposure is given, instead of asking them to engage in cognitive techniques, because it'll be very difficult, especially if the child is of lowered intellectual capacity, or if it's a younger child. Using more visual schedules involving the parent, giving very simple instructions, or giving handouts. So instead of using a subjective unit of distress, using something calling it a feelings thermometer, using worksheets. So this is how studies have been conducted, and ERP and CBT can be combined along with pharmacological management. There has been a report where deep brain stimulation was used in this, in a patient with OCD with ASD, and they have seen improvement in obsessive symptoms in this individual in an adult with ASD when stimulated the nucleus accumbens. This is one of the very difficult restricted repetitive behavior, and ASD is one of the very difficult symptom to treat in that sense, and largely behavioral management is being used, and they have also reviewed some 14 trials where they found there was no difference between the medications, where they used different SSRIs, risperidone, oxytocin, N-acetylcysteine, but there was no significant difference noted whether when they used SSRIs or a placebo. So again, this is one of the most challenging symptoms, one would say, in treatment. In the treatment of children with autism. Another co-occurring disorder is the anxiety, and the anxiety in this population also insist social situations can cause a lot of discomfort. Sensory stimulus, excess or less, can come. Been studies where they have used SSRIs and SNRIs. It's been used and considered to be first line because of its good efficacy, but still SSRIs, they have shown adverse effects of behavioral activation, increase in aggression, irritability, insomnia in this population. Again, very similar to OCD, the non-pharmacological measures would involve more of, would involve the parent using more visual aids, reinforcers where, the child interested in a certain object or child-specific interest can actually be used as reinforcers. Token economies, social skills in this population. Also, when we're using systematic exposure lists, which provokes anxiety, they encourage not to engage in the ritualistic. Exposed to that stimulus, they get habituated to that maladaptive physiological response, which they are learned to identify without escaping from that stimulus. So anxiety decreases over time, and there are more in vivo, practice of these skills which are carried out. So it has been tried in this population, but largely in the high functioning ASD, because also to do CBT, it would involve that kind of even engage in this, and they have demonstrated positive improvement in this population. The advanced novel treatments are where computer-based CBT has been tried, which is the CAMP COPE a lot, where they used a computer-based CBT program in youth with ASD, and but they didn't find any difference using manualized CBT and a computer CBT. So that this is one of the newer advanced one can say. Biofeedback has also been used in this population, where they allow increased emotional awareness and also an understanding of what exactly is happening to them while anxiety happens, like the physiological understanding of the physiological symptoms, the mouth going dry or the trembling, etc. And the system monitors, measures, and amplifies and gives feedback, so they become more aware and in control of their anxiety. Now, another molecule which has been implicated again in the dysfunction of ASD is melatonin. Melatonin, which is secreted by the pineal gland, is responsible for, is responsible, or rather increases towards the end of the day, responsible for the sleepiness and establishing a circadian rhythm. When there is a dysfunction of melatonin, it can result in oxidative stress, synaptic dysfunction, which is seen in brains of ASD individuals, right? Which contributes to its pathogenesis, and hence a low melatonin can result into, it's implicated in the pathogenesis of ASD. Hence the use of melatonin in especially those individuals who have sleep issues and anxiety. So abnormalities of melatonin secretion and circadian rhythm abnormalities are seen in these children. And hence they've also tried using prolonged release formulation. So melatonin, of course, will help in decreasing sleep latency, but when used, prolonged preparations were used, they saw that the sleep duration increase in these individuals. And when it's coupled with a behavioral management, so say if the sleep hygiene is taken care of, now these children are very prone to, they're very sensitive to stimulus. So a very calming environment, a very fixed bedtime ritual, a routine, scheduling, the bed timing. When these things, these behavioral issues, sleep hygiene principles, when they are used with melatonin, it can result in improvement in anxiety and sleep disorders. And a lot of times we have actually started using this even in our clinical settings. So yeah. Another co-occurring comorbidity is depression. So SSRIs have been tried, but there are no controlled trials in depression. And one of the Cochrane reviews where they have used antidepressants have, recommended the use of SSRIs for depression, although we use it in the clinical settings, but they say it case-to-case basis. TCAs, again, owing to their side effects in this population, has limited evidence. Again, the clinician has to be aware of the behavioral activation and suicidal ideas, emergence of suicidal ideas, and hence monitoring is recommended. In one of the studies, they have used repetitive transcranial magnetic stimulation in MDD in adults with ASD, and they found a decrease in depressive symptoms in this population. These are the two, neuropeptides, which are oxytocin and vasopressin. Now, they are released by the hypothalamus and gets released in the anterior pituitary, the different areas of the brain, the amygdala, the cortex, and a dysfunction in oxytocin can result in problems in social behavior because it is involved in the mesocortical limbic system again. Oxytocin, right from birth, to lactation, is involved in parent-child interaction, right? So it plays a very vital role in the social reward, in establishing social behavior, in trusted relationships, and it's very sensitive to emotional and social context. So if there is a disturbance of oxytocin, which they have reported in children with ASD, it correlates with symptom severity, and this is also seen. So to correct this issue, when oxytocin was given, intranasal oxytocin was given, like in children with ASD, it actually lit up certain areas. Like you can see here, it lit up the superior tegmental sulcus, which is responsible for social behavior, social perception, social processing, and emotional processing in case of amygdala. So there is evidence where oxytocin, when given, can result in improvement in this population, especially in the core deficits, but still more evidence is required. So there have been studies recently where they have used it in repetitive behaviors. It is implicated in repetitive behaviors, and once the synthetic oxytocin is given, it ameliorates it. But very little is known for this in terms of the long-term side effects. So oxytocin has shown promise, but we need larger studies to find very clear-cut benefits. So, and they've gone even further where endogenous oxytocin from the hypothalamus can get released by using MC4R agonists, which are the next generation therapies. And they see that as one potential in future, hopefully. Another molecule which is responsible for social cognition and behavior is vasopressin. So the vasopressin receptor variant, like when the gene is dysfunction, it's associated with ASD, and they have seen that in preclinical and animal models where an antagonist, is like when a selective V1A receptor antagonist, when given in this population in adults, can be a novel target for treatment of social deficit. So one of the molecules which is considered the breakthrough therapy designation by the US FDA in ASD to modulate these key behaviors, which has been tried in this population in a 3-month study in ASD adults, has shown improvement in social and communication scores. There's one study which is ongoing and another study which is just completed this year, but they did not show efficacy in children who are under 5 years of age in any of the core symptoms in autism. Psychosis and ASD again is co-occurring, and there are overlapping phenotypic and cognitive manifestations also that we know. So both psychosis in ASD and ASD in this population is seen. It's a comorbid disorder, but there are very few studies again in this population which have been conducted. They have used risperidone and aripiprazole. They have seen to decrease positive and disorganized symptoms in this population, but they come with their side effects that we're aware of. Gene therapy, which I think Dr. Gupta sir also mentioned towards the end. Again, this is for the researcher, not still for the clinician here, is you silently introduce or replace the gene. But again, these are all animal models, preclinical studies, but yeah, of research interest. So the current challenges which are which are there in these clinical trials is the fact that ASD autism is so heterogeneous in that sense because of the spectrum, that it becomes very difficult for only one molecule to target that one symptom, right? And a lot of times the animal studies, the preclinical studies do not get translated to clinical studies on patient population. Again, there are not validated objective biomarkers to diagnose and treat, and the relevant neural circuit which has been involved, and also understanding their clinical endpoints is a challenge. Also, we need to create more robust trial designs and regulatory requirements while these trials are being conducted. So in a nutshell, again, there are challenges in terms of differential diagnosis. Sometimes there are multiple symptoms which need our intervention, and it's very difficult to select and monitor for outcome, because it is one aspect is the pharmacological intervention which we spoke of. The other aspect is also treating the core deficits in terms of the social communication issues, which is largely taken care of the behavioral intervention. So how that is done is also another factor which in a way plays a big role in outcome. Also, this population is very prone to adverse effects, and there is lack of evidence base. Some more hope for, there are probiotics, cannabinoid oil, IVIG, which have been tried, but there hasn't been significant evidence, no convincing evidence of the same in this population. Other molecules like curcumin, luteolin, sulforaphane, they have been used, but again, it's at a very nascent stage when it comes to evidence. Limitations are, despite safety, most are not FDA approved. Unforeseen side effects, interactions, we don't even know, and there's limited research and experience. So the core deficits of ASD, we are where we are. Non-pharmacological interventions are used for core deficits. Just to encapsulate everything in this table. Irritability, we know risperidone, aripiprazole, the other antipsychotics, but the treatment advances are brexpiprazole, baclofen, N-acetylcysteine. Hyperactivity, stimulants being used, atomoxetine, clonidine. Naltrexone is one of the treatment advance. OCD, SSRIs have been used, but the adaptations of CBT, the different behavioral measures are something new. Repetitive behaviors, we know non-pharmacological approaches are being used. Again, SSRIs have been used, but the efficacy has not been proved in all the studies. Naltrexone is another molecule which reduces the repetitive behaviors and can be considered in this population when we know they don't improve in our setting. Anxiety, SSRI, CBT, we know. Advances are that there are adaptations of CBT, melatonin that we can use, and again, internet-based CBT. Depression, SSRIs we are using, psychosis, antipsychotics, and sleep problems, there's melatonin and behavioral measures. Oxytocin and vasopressin antagonists, they do offer some promise, but we need to see more evidence. Thank you.
Thank you so much, Dr. Mansi, for this up-to-date practical approach that you have brought about. There are some questions, some you have already spoken about, but if you could focus a little bit more on what you've already said. Dr. Prasad has asked, what is the role of L-carnitine in ASD evidence? I think you mentioned it, but a little more in detail.
Okay. So it has been tried, but there is no established evidence that they have really seen in this population. So they may use it, as an augmenting agent, but I haven't come across, any study or any RCT as such, which has spoken of it as an effective evidence. Yeah.
And this whole thing of stem cell therapy in ASD.
It's not recommended, and rather, I think the guidelines, which is written by Kirsi Chavra sir, which has come up, and the entire team has clearly said that it's not recommended in that population.
Yes.
Yeah, the CPG clearly says no stem cell. Yeah, discourages.
Dr. Gupta?
Yes, sir. The next question is about how the comorbidities are assessed in ASD rating scales.
So I think we can't talk of one comorbidity. Say when we're talking about irritability, the studies have used aberrant behavior checklist, and they have used CGI, which is the clinical global, impairment scale. In terms of OCD, they have used the CY box. In other depression, they have used the routine, children depressive inventory. So there haven't been any ASD specific, as such rating scales. So the rating scales that we would use in children have been used in this, population while assessing the different comorbidities. Yeah.
Dr. Sohaf has asked role of artificial intelligence in the management of autism.
I mean, role of artificial intelligence and virtual reality, I haven't researched that to that extent, but I think I would just talk about the technological advances where they have used neurofeedback, and they have used, internet-based, software programs to use the CBT and all of that. But the role of virtual reality perhaps is something that, for the treatment of anxiety in these patients, so that they could simulate anxiety in such, and give them an exposure of a certain stimulus. But I think most of these interventions would need, the parent or a co-therapist, especially because these children do need a lot of help and support. So not sure of this one. Yeah.
How much effective, he's again asked, how much effective is ketamine in treating autism?
No, there haven't been many studies on ketamine and autism. Yeah. Even vitamin D, I think someone just posted, they have tried, but there hasn't been any convincing evidence of in that.
And then another question is, what is the best treatment for hyperactivity in a 6-year-old child?
I think we will go with the first line management. There have been studies which have supported methylphenidate and atomoxetine. So what we routinely do in our clinical settings when a child with ASD and hyperactivity presents to us is to consider pharmacological management in the form of methylphenidate and atomoxetine. And you would also use the non-pharmacological measures in this population. And, clinically, we would also advise occupational therapy, in this population. So, yeah.
Yeah. So back to you, sir.
Yes, sir. Dr. Mansi, hypothetically speaking, could you ever envisage a time when, just like we're doing in vitro stuff, or we're doing stuff when a person, when a lady is pregnant, and then we can say that there are problems associated and it might be a good idea to abort? Point number one, all hypothetical, but let's look for the future. Could you ever see that maybe some test can be done when the woman is pregnant where you can prophesy that the person might have ASD in the future? And number two, if you do prophesy it, can you ever think that there would be ethical issues associated with a possible abortion?
The second one is really difficult, a very difficult question to answer. I don't think.
I don't think so either, but I was just wondering, yes.
but gene therapy experts, I don't know what they have to say. But again, these are preclinical studies, and to translate that into clinical and patient population seems to be
It's
a
very
very
difficult.
difficult.
Point number 2. There have been occasional cases where more than one child in a family have had ASD. Is there any specific alteration or any specific change or any specific thing that you can think of which would actually have this occur in a family? I mean, dealing with one kid is bad enough. Dealing with 2 kids with ASD is horrendous. Can you think of anything that might have caused this to happen?
I mean, I think there is a genetic basis to this, but
The specifics we don't know.
yeah, I won't be
Okay.
able to.
Fine. We've got a lot of very senior people also who have got in. Dr. Prasad, anything more? If you're around, anything more you want to add? Okay, we are not sure if he's around. Dr. Sukumaran, he has liked your talk very much. Sir, is there anything specific that you'd like to ask Dr. Mansi? Are they allowed to they can unmute, yes. Please unmute if there is a question. Sir, we can't hear you. You're muted. Please unmute yourself.
Have any specific question? I was appreciating her very comprehensive and wide of this vital topic, and a lot of pharmacological, very variety of pharmacological with various type of actions have been used.
Yes.
What is the broadly? What is the rationale of using such a panoramic, wide variety of pharmacological agents?
Yes, sir. Thank you. Dr. Hemant Belsare, he's also a very senior person from Mumbai. Hemant sir, anything you want to add? Not sure if he's on. Dr. Prasanjit, since you're there and you're smiling away, something from you.
Thank you, Karthi sir. I will speak at the end.
Okay.
Dr. Taura, there is a question actually which has been already, and I wanted to actually know about it. Very curious that parents come, particularly who have ESP as their
Right.
child, and they ask about specifically about the diet, what we are supposed to give and what we are supposed to avoid. Is there any specific role of diet in patients who are suffering from ESP?
So a lot of there's a lot of evidence where they have suggested that we should give casein free and gluten free diet, and because the gut of individuals with ASD cannot hydrolyze certain peptides, but there hasn't been that's not an established it doesn't have that established evidence in that sense, so this has been proposed, and I know a lot of people, a lot of parents with children with autism, they start doing that, but it's not a recommendation in that sense.
In fact, I have one of my known persons who works with autism children in one of the metros, and he would. I heard his talk once, I think a month before, and he emphasized a lot on diet, but I was not really convinced. The reason being that there was hardly any data to support what he was saying, but all talk was about the dietary restrictions and encouraging children to do this and not to do that. So I thought that maybe there is some data which is available.
So for what it is worth, I have worked with an institute which had a lot of ASDs. This is about 20 years ago, where there was this excitement related to having kids with ASD put in some, they were made to listen to sounds of particular frequencies. And it was believed that that would make a difference to the way they started to behave. Nothing really happened. But what was strange was that there were about 2 or 3 kids who used to walk on their toes. And after this, after about 10 to 15 sessions of this, they actually started walking well. And there's no explanation we can give for that. But that did happen. In my time, I mean, I'm so much older than you guys. We talked about this diet thing very often. We spoke about gluten-free, we spoke about refined sugars, and we spoke about flour, refined flour. Those were the 3 things that we felt aggravated an ASD and aggravated attention deficit. Didn't cause it, but anyway, it would be healthy not to give all of that. So it was just a general recommendation. And of course, your high doses of vitamin D that was used profusely at one time. It seemed to help, especially those who seem to have some kind of epileptic issues as well. For whatever reason, that seemed to help. Just by the by. Now, all of this is now gone by the side of the road as more and more advances have happened, but we all get very excited when something new comes about.
Mansi, may I ask you one question? Like the role of omega fatty acids, particularly high. What is your experience?
No, I don't really have an experience of giving it, sir, but yes, I did read it while we were, while I was studying about this, but they have tried it in this population, but like I said, it doesn't have, an established evidence in this population. Yeah.
Okay.
Dr. Majid, back to you.
Thank you very much, sir. I think we have a president of IABP, Dr. Prasanjit, who is here, and he would surely like to thank the wonderful lecture that was delivered by Dr. Mansi and moderation of Dr. Kersey and Dr. Nitin Gupta. Dr. Prasanjit, kindly go ahead.
Thank you, Dr. Majid. I, on behalf of IABP, would like to appreciate Dr. Mansi Sumaya for enlightening us in the field of recent advances in the management of autism spectrum disorder. And also, she talked very nicely about the future challenges and future directions. We are very much thankful to fine academicians and very eloquent speakers who chaired today's CME, Dr. Kasi Chawra sir and Dr. Nitin Gupta sir. We are also very much thankful to all the participants for making today's CME a very interactive one. We are thankful to our CME chairperson, Dr. G. Prasad Rao sir, for his continuous guidance. And we are also thankful to our Vice President and Senior Member, Dr. Sunil Mittal sir and Dr. Pramod Kumar sir. Although today we don't have our President, Dr. Garg sir, and our General Secretary, Dr. Rutseda, our sincere thanks to both of them for continuously organizing this event, Friday CME. And last but not the least, I would also like to extend our sincere thanks to our office assistant, Ms. Amita of Medisphere. Thank you all for joining us tonight and making this CME a very successful one. Thank you.
Thank you. Good night. Take care. Bye-bye.
Thank you.
Thank you. Good night. Good night. Good night.